everyone. I'm Elaine Congress. I'm at Fordham, Associate Dean and Professor, and I head the UN Student Group, and we're very involved in putting on our conference today. First, I want to welcome everyone to this very exciting conference. Our theme, as you know, is United in Healing, and we're focusing on combating gender-based violence across generations and around the world. This is, it will be a very exciting conference. Our Fordham UN students have teamed up with our Australian colleagues, medical students from Notre Dame, and putting on this conference. As you may know, the University of Notre Dame is our longtime partner in terms of putting on conferences and working with them. It's headed by Gabriel Casper. So we're very excited, about this conference. But before we begin, I want to have special thanks to our IT team at Fordham. Connor White, for Trish Rodriguez, and Matt Roach, who are just wonderful, have really made it possible for us to put on this conference. Also, I want to especially acknowledge our Fordham UN students, and maybe special kudos to Maria Taloni Perlette, who's kind of really led our students and kind of organized us all in running this conference, and also has the other coordinator for this conference, Alina Solar, who really has helped us with a lot of IT issues. And I also want to ask you, if you have any problems or issues, during the conference, please put in the chat, and she will try to address these problems for you. Now, also, we have other students who will be presenting today. We have Carla Mayelas. We have Monica Mendez. We have Anise Fernandez, and let's see, Amishi Kugel. So we have many of our Fordham students are going to be presenting at this conference. So and also let me just say that it will be recorded. I know there are often people who end up having a conflict, so they're not able to attend, but who really want to hear what's going on. So you can reassure your friends and colleagues that there will be a recording made. In fact, it's already in process. So without further ado, let me turn the program over to Maria, who will kind of walk us through what we're going to be experiencing this afternoon, or maybe this morning for those of you from Australia.
Before we begin, I would like to thank my mentor, Dr. Congress, who has taught me that this work is both a responsibility and a calling. Her guidance and leadership has a lasting impact on my academic and professional journey. Thank you for believing in me, in this work, and in all of us. It is an honor to welcome you all to this conference focused on one of the most urgent human rights issues of our time, gender-based violence. This is not an isolated problem. It is systemic, rooted in inequality and power, and it affects millions across the globe, particularly women, girls, and gender-diverse communities. And yet, we are also here because of resilience, because of survivors who refuse silence, practitioners who create care where systems fail, and advocates who have reshaped laws and lives. Today is not just about learning. It is about listening, reflecting, and committing to action. Change happens when knowledge is paired with justice. Thank you for being here, for caring, and for standing on the side of dignity, safety, and human rights. It is now my pleasure to welcome Maisha Kogel, a Master of Social Work candidate at Fordham University and a UN intern under Dr. Elaine Congress. She holds a bachelor's degree in forensic psychology from John Jay College. She works as a child protective specialist with New York City's Administration for Children's Services and brings 6 years of experience supporting children and families.
Thank you, Maria, and thank you again, everyone, for gathering for this most important conversation. We wish to begin with a brief overview of gender-based violence. So, what is gender-based violence? It is any act of harm that is perpetrated upon an individual because of their gender. Most often, it affects women and girls, and it is estimated that 1 in 3 women will experience sexual or physical violence in their lifetime. Gender-based violence includes physical, sexual, and emotional abuse, as well as threats, control, even taking away someone's freedom. Gender-based violence is a human rights violation and it is preventable. And we often find ourselves asking, why does it happen? And the main cause of gender-based violence is inequality, unequal power and discrimination between men and women. And when one group has more control over the resources, decisions, opportunities, it creates an imbalance that unfortunately can lead to violence and abuse. One of the most common forms of of gender-based violence is intimate partner or domestic violence. And this includes, again, physical aggression, sexual coercion, emotional abuse, even financial control. And it's important to note that this can occur between current partners or ex-partners. And we also need to recognize that domestic violence is broader. It can include child or elder abuse, not just violence between romantic partners. And understanding this helps more people realize that what they are experiencing could be abuse. There are other forms of gender-based violence, such as harassment and rape. Also, exploitation is a form. Femicide, which is the killing of a woman, again, because of her gender. Human trafficking is also a form. And harmful practices such as female genital mutilation and child or forced marriage. Today, we also have online violence, technology facilitated abuse, cyberbullying, sharing private photos without consent, or doxing, which is when someone's personal information is posted to cause harm. And these can have serious emotional and psychological effects. So again, at its core, gender-based violence is about power and inequality, but awareness is the first step to change. And by learning more about gender-based violence, also recognizing the signs and supporting survivors, we can all help build safer and more equal communities. We will now hear from Charlotte Wignall and Susanna Gooley. Charlotte is a third-year medical student at the University of Notre Dame, Australia, with a background in pediatric nursing. She has lived most of her life in rural communities where she witnessed firsthand the health inequalities faced by women and children. She has also worked with an emergency center for women and children affected by violence, which has shaped her commitment to expanding equitable health care and addressing gender-based violence. Susanna is a third-year medical student at the University of Notre Dame in Sydney, Australia. She holds a Bachelor of Advanced Science in Biological Sciences and has 4 years of experience in medical research. She also has a strong interest in women's health and is committed to ensuring that women receive appropriate care across all stages of life. She is also focused on the intersection of climate change and health, especially its impact on vulnerable communities.
Thank you so much for that introduction, and good morning from Australia. My name's Susanna Gooley, and I'm going to be joined today by Charlotte Wignall, both medical students from Notre Dame. Today we'll be presenting on responding to survivors of sexual assault, a topic that's deeply important to us as emerging health professionals. This presentation was developed with the generous support and guidance of Dr. Mary Stewart and Dr. Julie Protis from the Northern Sydney Sexual Assault Service. We also just wanted to take a moment to acknowledge that this session does include some clinical information and descriptions of sexual violence and assault, which may be distressing, so feel free at any point to take a break if needed.
The World Health Organization defines sexual violence as any sexual act, attempt, or behavior targeting a person's sexuality carried out through coercion by anyone in any setting. Sexual violence experiences are individual and diverse. Our clinical approach must recognize all forms and understand the medical, psychosocial, and safety implications. Sexual violence remains a global public health crisis. Globally, 1 in 3 women experience physical or sexual violence in their lifetime. Sexual violence is one among the world's lowest reported and lowest prosecuted crimes, with underreporting exceeding 80% worldwide. In New South Wales, Australia, sexual violence disproportionately affects women, reflecting broader international trends. These realities highlight the importance of a trauma-informed, proactive approach in healthcare settings. While most survivors may never engage with the legal system, many do seek care and providing critical opportunities for us to provide support and intervention. Sexual violence has far-reaching effects. Survivors face higher risks of sexually transmitted infections, unintended pregnancies, and complications like miscarriage or preterm birth. It can also have generational impacts, as children who witness violence may develop emotional or behavioral difficulties, and survivors may experience repeated victimization. Beyond health, there are social and economic consequences, including isolation and lost income. These realities highlight why a proactive approach in healthcare is essential.
After a sexual assault, health professionals are often the first person that a survivor will speak out to outside of their family and friends. With more than 1 in 5 women making their first disclosure of domestic or sexual violence to their general practitioner, with full-time general practitioners seeing up to 5 women each week who've experienced intimate partner abuse. This means that whether or not your patient directly says, "I've been assaulted," most healthcare professionals are working with survivors, and therefore our response matters. Disclosing sexual violence is incredibly complex. Survivors are often reporting harm by someone they love or depend on financially, emotionally, or for housing. Shame, fear of judgment, fear of not being believed, and fear of the consequences all contribute to their silence. On top of that, poor service experiences can themselves become a barrier. Research has shown that when survivors receive dismissive or unhelpful responses, even once, they delay seeking help again, sometimes for years. A single poor response can often close the door to vital support. This is why it is important to facilitate disclosures wherever appropriate. If we don't ask, we risk treating symptoms such as anxiety, pain, relationship issues without ever addressing the underlying trauma. Survivors themselves don't always make the connection between their current health concerns and their past abuse. In a paper published by Bond et al., they described that many survivors had years of contact with health professionals who never asked the right questions. For some, naming the experience shifts their self-perception from something that's wrong with them to something that happened to them, which is a critical step in recovery. We can identify sexual violence through 2 main approaches. The first one is through case finding, where we ask sensitively when a presentation raises concerns or where behavioural cues suggest some level of distress. And secondly, through routine screenings, which is now embedded across New South Wales Health, particularly around antenatal care, child, family health, mental health, and drug and alcohol services. These pathways help to normalise the conversation and give survivors permission to disclose in a safe environment. It is important to remember that disclosure unfolds over time. Survivors may often hint, minimise, or test healthcare providers' reactions before telling the full story. For many people, saying the words out loud is frightening, emotional. So the response they receive in the moment must be calm, validating, and supporting. A single negative reaction can halt this process entirely. It is therefore important that clinicians be mindful of how they respond when a survivor discloses sexual violence. These conversations can evoke strong emotional reactions: shock, sadness, anger, even excessive protectiveness. If we're not aware of this, our own responses can unintentionally cloud our judgment or overwhelm a survivor. A therapeutic response needs to be calm, grounded, and supportive. The goal is not to investigate or gather details, but rather to create safety and stability in the moment. A good response is believing, non-judgmental, and empowering. Simple phrases like, "I'm sorry this happened to you," or "Thank you for telling me you're in control of what happens next," can make a huge difference. From there, it is possible to gently explore their immediate needs, including their safety, any medical concerns, and whether or not they'd like any support from any sexual assault services. A validating response in those first few moments can shape the way a survivor engages or withdraws for cares for years to come.
After a survivor discloses sexual violence, the following clinical management steps follow, ranging from immediate medical care to follow-up and support. In New South Wales, all sexual assault responses run through the New South Wales Sexual Assault Services organisation, based in major hospitals. The survivor does not need to involve police in order to receive either medical or forensic care. If a forensic examination is completed, evidence can be stored, giving the survivor time and control over their decision-making. Sexual assault is often accompanied by other injuries. Strangulation is especially high risk, as survivors can appear well initially and then decompensate hours later. Any intoxicated survivor needs monitoring to rule out head injury, aspiration risk, or ongoing toxicity. Safety assessment is essential. We can explore immediate safety, perpetrator proximity, children at risk, and red flags like weapons, escalation, and stalking. This guides whether mandatory reporting, police involvement, or urgent safety care planning is needed. The clinical setting can mirror aspects of the assault, by offering choice, privacy, breaks, and continuous consent. It reduces re-traumatization and can improve survivor engagement with the healthcare process. Before any examination or intervention, the most important step is explaining the process clearly and obtaining fully informed ongoing consent. Many survivors arrived overwhelmed, distressed, or unsure about what will happen, and a simple, calm explanation can help restore a sense of control. In New South Wales, survivors can have two options. They can have medical care, which involves treating injuries, preventing infections, and checking well-being, or forensic options, which involves collecting evidence if wanted. Clinicians can move through each consent area, ensuring the survivor understands what each part involves. Consent in this process is modular, which means survivors can choose what they do and do not want. For example, they might agree to a medical exam but not forensic swabs, or have swabs but skip photographs, speak to the police now, later, or not at all. This approach supports autonomy and is a key part of trauma-informed care. It's also important to make clear that consent is ongoing and whatever choices they make will not affect the care they receive. This helps reduce the fear of being judged or disappointing staff. The New South Wales medical assessment focuses entirely on the survivor's physical health and well-being. It is a non-judgmental, non-investigative, and optional process and does not determine whether assault occurred. Its sole purpose is to care for the survivor and to address risks and ensure safety. The medical examination can consist of a general examination, a head-to-toe assessment, or a genital examination. However, many survivors decline genital examinations. All examinations are performed gently, slowly, and with ongoing consent. The exam follows a trauma-informed pattern, starting with non-invasive steps, narrating actions as they're performed, and pausing if the survivor is distressed. Injuries are documented accurately, but never interpreted, and pain medication is always offered. Forensic examinations preserve choice. Forensic examinations in New South Wales are conducted by specialised trained doctors and clinical nurses and involve evidence collection and documentation, as well as medical and psychosocial support. Survivors who initially choose not to report may choose to report later, and store evidence may be critical down the line. The forensic assessment includes history for forensic purposes, evidence collection and injury documentation, and toxicology. Evidence bags are labelled and sealed immediately, and handover is recorded between every clinician. Evidence is stored securely and released only when the survivor consents to police involvement. Survivors can choose to never release the evidence, but can still be assured that evidence will be stored for a minimum of 3 months if they change their mind. Photography may also be collected and is a sensitive procedure. New South Wales requires strict consent, skilled clinicians, and secure storage. Survivors, like everything else, can also withdraw their consent later before evidence is released. Many survivors experience a psychological reaction to sexual violence. Long-term reactions emphasize the importance of managing medical risks and organising follow-up. The New South Wales Protocol emphasises informed choice around STI testing, pregnancy prevention, and HIV prophylaxis. Many survivors feel overwhelmed, so written and follow-up instructions are critical. Risk assessment is tailored to each survivor. The type of contact, contraceptive use, injuries, and the patient's vaccination status are all considered to decide whether STI testing and prophylaxis, emergency contraception, or any combination are warranted. Immediate serology testing is performed for STIs, and the survivor needs to be made aware of any required repeat future testing. If the exposure is high risk, prophylactic treatment can avoid the distress of waiting for results. In follow-ups, survivors are offered a medical review, STI and pregnancy follow-up testing, a referral to the local New South Wales Sexual Assault Counselling Service, ongoing HIV prophylaxis, ongoing safety planning, and information about reporting pathways.
As medical students, learning about sexual violence early in our training, how it presents, how to recognise it, and how to respond has been invaluable. It meant that when we encountered patients who had been sexually assaulted, we had the confidence to ask them sensitively, to listen without judgment, and to know what to do with that disclosure. This education allowed us to offer more compassionate, informed, and trauma-aware responses. From our experience, this training is essential and should be available to not only all medical students, but all health professionals, including allied health, so that every survivor is met with understanding, safe, and supportive care. Thank you so much.
Carla Miles is a social work student and intern committed to supporting children, youth, and families through challenging transitions. She has experience working with immigrant students, shelter-involved families, and young people facing academic and emotional difficulties. Carla brings cultural awareness, compassion, and a strong commitment to advocacy.
Thank you, Maria. Today I'll be presenting 3 brief case studies about young girls from different countries who have faced significant challenges, including early marriages, trauma, displacement, and limited access to education. Each story highlight how these girls were affected and how their resilience helped them move forward. These cases help us understand the impact of gender-based barriers and the impact of importance of support, protection, and education for young girls. Case 1 is Ali. She is from Yemen. She was married at the age of 10 to a man that was in his 30s. She experienced sexual and physical abuse. She escaped and became the first bride in Yemen to obtain a divorce. Now she is a symbol of resistance and advocate for children's rights, though she continued to face social and emotional challenge. In a famous quote about her, she says, "I no longer think about marriage. I just want to go to school." The second person is Sherry Johnson. She's from the United States. She was forced to marry her rapist at the age of 11 after becoming pregnant. She endured several years of abuse within the marriage. She became a national advocate for child marriage survivors. She helped change Florida law to ban marriage under a certain age, bringing national attention to the issue. Case 3 is Fatima. She's from Sudan. She was married at the age of 12 and gave birth at the age of 14. She experienced severe reproductive trauma, including complications from early childbirth and long-term emotional distress. As an adult, she became an educator who teaches young girls about their rights, safety, and the importance of schooling. She used to live her life experience to advocate within rural communities. Okay, why are these cases important? These cases are important because all 3 girls, they were forced into adult roles before they were physically or emotionally ready. Their childhood were replaced with fear, responsibilities, and trauma. But also education disruption, child marriages pulled them out of school or limited their opportunities. As an adult, all 3 expressed a deep desire for education, either for themselves or for other girls. The impact they're all faced were abuse, violence, whether it was physical, sexual, or emotional, all 3. These experiences shape their self-esteem, sense of safety, and a long-term mental health. Psychological and emotional trauma. Each experience long-term mental health effect, including anxiety and fear, depression, sadness, trauma from sexual and physical abuse, difficulty trusting adult or forming healthy relationship, emotional pain tied to their early experience. The good thing that came out of this, despite their trauma, all these three women eventually became advocate for young girls, spoke about girls' rights in education, and Cherry fought to change the US law around child marriages in America. And Fatima teaches young girls about safety and their rights within her community. Why is this issue so important? Child marriages is not only a cultural issue, it is a global human rights violation. It causes both physical harm, dangerous pregnancy, injuries, health complication, and serious mental health harm, trauma, depression, and lifelong emotional scars. These cases show that child marriages can occur anywhere in developing nation, rural areas, or even within modern Western countries. Ending child marriages means protecting children' mental health and education, safety, and futures. Monica. Monica is a master of social work candidate of Fordham University with multidisciplinary background in healthcare leadership, education, and human services. She holds an MBA in healthcare administration and data analytic, a Master of Science in Health Science, and a Health Education Specialist certificate. Monica has supported pediatric psychosocial care at New York Presbyterian Morgan Stanley Children's Hospital and coordinated early intervention service for children and families. She is bilingual in English and Spanish and passionate about global health system, gender equity, and the well-being of vulnerable population.
Thank you, Carla, and thank you for everyone who's joining us this afternoon. And in some locations in the morning, I'm going to be speaking on healing in crisis, gender-based violence preparedness across health systems, climate change and gender-based violence, the connection. As temperature on the planet increases, climate change will continue to lead to severe weather storms, drought, heat waves, fires, sea level rising, and floodings. These extreme weather events lead to displacements, food insecurity, lack of access to healthcare, and economic instability. Women are mainly impacted as women and girls are disproportionately affected by climate crisis. Systemic inequalities and social roles make women vulnerable when extreme weather disasters happen, and this leads to higher levels of anxiety within households, increasing gender-based violence. Research shows that rates of abuse increase during climate emergencies. Specifically, women between the ages of 25 and 45 are at higher risk because of the domestic responsibilities and financial crisis, particularly for marginalized women such as Indigenous women, migrants, and women who live in low-income communities. Health systems and impact on survivors. Providers are often the first point of contact for women during climate crisis. In these moments, women may require reproductive care, trauma support, mental health services, and treatment for physical harm. Health facilities play a critical role in identifying cases, yet multi-sectoral support remains limited. Many providers are not adequately trained, largely because of funding shortages, which prevent facilities from developing emergency plans that include gender-based violence. Even when resources are available, addressing violence is often not prioritized, which requires highlighting the need for greater awareness. There is also a lack of safe and private spaces for women to report, along with language barriers and limited tools for communicating with survivors. Data collection represents another major gap, as there is no cohesive reporting system or consistent tracking to determine who is affected. These barriers can make women afraid to come forward. Health systems must not only incorporate gender-based violence into their emergency planning, but also coordinate with shelters, the police, and other community services to ensure an effective response during climate crisis. Improving gender-based violence responsiveness in health systems. To improve gender-based violence responsiveness in health systems, specifically during a climate crisis. It is essential to strengthen provider training and expand trauma-informed approaches so providers have the tools needed to support affected women. Health systems must also create crisis-ready clinical spaces where women feel safe to report what they have experienced. In addition, establishing an effective referral system is crucial, not only to assist survivors during the immediate crisis, but also to ensure they receive long-term support through connections with services outside the health system that can continue their care. Lastly, building resilience through action. Awareness and action are needed to support women in vulnerable settings, and several steps can strengthen health systems during a climate crisis. Some of those actions taken could be funding gender-based violence preparedness across levels of health response. It ensures that health facilities have PEP kits, emergency contraception, and the tools needed to support victims. Promote climate resiliency in health systems that are survivor-centered, which requires equipping facilities with safe and private spaces for women. Also, we can support and invest in community networks focusing on elevating women's leadership, which includes working with women-led organizations that provide survivor outreach and ensuring they receive necessary grants. And lastly, advocating for policies that require the inclusion of gender-based violence preparedness in health systems emergency operations plans. This requires working with policymakers to include screening protocols and data tracking in emergency planning. And now my colleague Maisha is going to rejoin us.
Thank you, Maria. We will now examine domestic violence intervention and prevention. So as we mentioned earlier, domestic violence is one of the most common forms of gender-based violence. And what is domestic violence? For one, it's an epidemic, which is only a fraction of a larger systemic issue. It's also a pattern of abusive behavior, which is meant to gain or keep control of an individual. Domestic violence is willful. The person causing harm means to do this, and their behaviors can include anything from intimidation and coercion to blaming, hurting, and as we so often sadly hear about, injuring or wounding a partner. And it's also important to note that domestic violence can involve actions, not just the threats. Even a threat is a form of domestic violence. Now, as social workers, we are most often involved in the early identification of domestic violence, typically through screenings. And we're also heavily involved in intervention once a survivor seeks support. And that can look like safety planning, connecting survivors to shelters and legal services. We also collaborate with law enforcement, courts, etc. Clinical social workers provide trauma-informed counseling. And we are also involved in prevention and education. So domestic violence prevention literature often highlights our intervention strategies. However, as we discussed, social workers are involved in both. Regarding domestic violence, however, we're usually more focused on intervention. And the reason for that is because domestic violence is underreported. So a survivor is often seeking help after the harm has occurred. And as a child protective specialist, this is my experience. I enter a survivor's life during the crisis, and I often find myself wondering what we can do to strengthen our preventive efforts. As social workers, we traditionally teach communities about prevention through awareness campaigns about the warning signs of domestic violence and sharing available resources such as shelters and counseling. But we can go a step further and create new opportunities to discuss not only the warning signs, but healthy relationships as a whole. And ways that we can do this is by stepping outside of our current roles and collaborating with others. This would look like a clinical social worker doing a presentation at a school, or a school-based social worker collaborating with a clinical social worker to do a workshop within their practice. A professor could gather students or interns to facilitate a workshop. It could look like social workers speaking at local religious institutions. So we have an opportunity to create our own new opportunities whenever possible to educate on healthy relationships as well as the warning signs. And perhaps these small steps can develop into a larger impact. Thank you. And now we will hear from Dr. Sarah Brody. Dr. Sarah Brody is an advanced trainee in psychiatry of old age at St. Vincent's Hospital in Sydney and a member of the Royal Australian and New Zealand College of Psychiatrists. She has worked in both the NHS and the Australian healthcare system, developing a strong interest in the social determinants of health and the impact of gender-based violence on health outcomes. She is committed to trauma-informed, person-centered psychiatric care and to improving mental health outcomes for marginalized populations.
Hi, thank you for that. So yes, I'm Sarah. Hi, I'm speaking from Sydney today, and I'm going to speak a bit about gender-based violence in older women with more of a psychiatric or a medical lens. I'd just also like to acknowledge the Gadigal people of the Eora Nation, the traditional custodians of the land that I'm on today, and pay my respects to their elders past, present, and emerging. So I think first off, it's trying to understand who counts as an older woman. The United Nations defines older women as someone over the 60. However, there's actually no global consensus on when old age begins, in large part because the perception of aging varies by individual, the community you're in, cultural and societal contexts. In Australia, we define in our health system someone over 65 as an older person, or if Aboriginal or Torres Strait, over 50. I've put a picture here of, sorry, if you just go back there. I've put a picture here of Oprah Winfrey. She at 71 would be defined as an older person, as would Miss Jenna here at 70. However, often when we think of older people, we are thinking of someone who is a bit grey and old, and we have an image or a stereotype of what old age is. However, this then leads to older people being missed as a population, and it shapes really how systems and organizations prevent and respond to intimate partner violence in older people. Often older people aren't seen as sexually active, don't experience sexual assault, don't repartner, they're weak, feeble, or they're too old to ever change their lifestyle, which means they're overlooked often when it comes to intimate partner violence. What kind of violence actually do older women experience? Well, I think it's important to just think about the types of violence that women have experienced across their lifetime: physical, sexual, psychological, emotional abuse, as well as financial and coercive control. Don't just stop because someone reaches an arbitrary age that's defined as old. One of the few prevalent studies that focused on violence and abuse in older women over 60 found that 28% of women reported some kind of abuse in the previous year, and intimate partners still being the most common perpetrator for all kinds of abuse except neglect. Neglect is something that potentially is more specific to older people and a violence that occurs there, and Michaela will speak more to that. Why it matters? Well, there's many reasons why it matters, but given that there is an aging population, and women aged 50 represent nearly a quarter of the women around the world, and that the population is going to reach around 1.4 billion by in the next 5 years, unfortunately, intimate partner violence against older women is likely to increase. As a doctor, and specifically working in mental health, we can often be the first point of contact for people within the health service, in the emergency department, or in reviews who may be survivors of intimate partner violence. And I'd like to share a case with you. So I'd like you to imagine that you are Angela. You're a 69-year-old Greek lady who lives with her 80-year-old husband in a small flat in suburban Sydney. You have no children, no government supports, no relatives. You used to work as a teacher but retired about 10 years ago, and now you spend your day doing some chores, maybe going to church, and really looking after your husband. Your husband of 45 years has recently been diagnosed with Alzheimer's dementia, and he's had a few hospital admissions recently. As part of his dementia, he's developed delusional ideas that you have been possessed by the devil, and is paranoid that whenever you leave the home, you're conspiring against him. He's actually made threats to hit you, to kill you, and he gets very angry whenever you leave the house to go to even the supermarket. He actually placed his hands around your neck a few weeks ago when you came in. He calls you names. He says you're a bitch, says that you're naughty, says that you're plotting against him and stealing his money. You tell yourself, I'm not worried. It's going to be okay. He's too frail now to do anything to actually hurt me. The geriatricians have previously suggested that he should go to an aged care facility because of his care needs, but you have this sense of duty that you can't do that to him. People would judge you, and this is just your lot, and you just have to deal with it. And very dismissive of your safety concerns. We actually were referred to see Tom by the geriatricians to try and help treat some of his delusions that he was happening. What transpired is that Tom is actually a proud Greek man who's probably had some narcissistic personality traits throughout his life. He's been a hard worker, but is prided himself in being in charge of the family, charge of the money, which he's no longer able to do. He's also had gambling issues and alcohol issues throughout his life. He's very open that he's actually been physically and verbally abusive towards Angela throughout the whole marriage, and it's evident there's been coercive and financial control. Now that he has Alzheimer's dementia, he's functionally and cognitively declined and needs assistance to wash, dress, leave the house, and is quite bored. He dislikes Angela going out, and he's ashamed of his loss of independence. When we see Tom, there's no real safe space to speak to Angela, given our concerns about what's been highlighted in our review with Tom. So we end up making an appointment to see her separately. And Angela discloses to us this lifelong history of violence across the marriage that she's never disclosed to anyone, and her current worries about what's been going on. Clinicians like myself have arguably an opportunity and a duty to recognize and respond to older people like Angela experiencing intimate partner violence. However, a significant barrier can be creating an environment that's safe to be able to discuss and give people the time to do that, especially in people's own homes or in emergency departments. Trying to build that private space, a safe environment, gives people a chance to give the disclosure, as well as recognizing the need potentially for an interpreter, not using family members, any cultural safety concerns where people may have had poor experiences in the past with health services or government, which may be a barrier to them disclosing. It may be with older people that you have to adapt your communication style because of cognitive impairment, and giving people time. So something that potentially they've kept secret for the past 50 years, to disclose what's been going on and listen carefully and validate their experience. In New South Wales, for all women presenting to a mental health service, screening for domestic violence is incorporated into routine assessment regardless of age. However, even if it's a non-mental health assessment, clinicians are required to ask direct questions about domestic violence when it might be suspected. We caveat this screening with a preamble that explains why we do this with all women. However, it can be challenging often to ask older women, partially because of this preconceived ideas that intimate partner violence is a younger woman problem, or embarrassment often on the clinician's part due to it feeling like it's too intimate to ask older people or disrespectful to ask them and someone who's older than themselves. However, the questions here have been tested to maximize their acceptability to women, and research clearly indicates that women are more likely to make disclosures of domestic violence if they're asked directly about it. So the first question that we always ask is, within the last year, have you been hit, slapped, or hurt in other ways by your partner or ex-partner? It may be that you have to sort of explain what other ways might mean to women as well. The next question is, are you frightened of your partner or ex-partner? If a woman answers yes to any of those questions, it leads on to the rest of the screening questionnaire, which is about asking if they feel safe to go home, if they need assistance with this, and if there's any children, or in the case sometimes of older people, grandchildren that are involved. With older women, you may not always have a high suspicion due to this implicit bias relating to their age. So some of the signs of behaviors that might make you more suspicious and to ask these screening questions is if there's been ever a documented history of past violence in the marriage. If there's any cognitive decline in the women that you're seeing, because that can often make them vulnerable, as well as actually if the partner has a history of cognitive decline because of the effects that executive dysfunction can have on aggression and cognitive flexibility to modify behavior. Similarly to younger people, looking out for physical signs like bruises, unexplained injuries, repeated presentations to doctors, nutritional deficiencies, and then psychological signs. That's particularly in mental health. We see a lot of women who present with low mood, anxiety, depression, suicidal thoughts that are related to stressful psychosocial contexts. Looking if they've withdrawn from their normal groups, if they're fearful of someone at home, and if there's any sort of psychotic symptoms as well. Also to think about is if there's any social concerns with, does the woman have access to their own transport? Does she have access to finances? Can she use technology? Is she socially isolated? If any of those happen, it might be worth screening a woman again with those questions. Similarly to younger people, if there's any history of alcohol and drug use within the home, it's worth asking some screening questions. I speak to some screening tools that I found useful when you're working with older women. And the dial of power and control wheel on the right gives examples of behaviors commonly used by perpetrators of domestic violence. The identification of abuses using this visual depiction can help build an overall picture of the relationship dynamic and also double as an educational tool, given that often older women may not recognize themselves as survivors of violence. For example, with Angela, using this tool, she could actually point to things that have been happening now and during her life, such as isolation, emotional abuse, intimidation, economic abuse, and coercion. So responding to intimate partner violence in older women, it requires a coordinated approach that's specific to the circumstances of that person. This may involve old age problems such as frailty, caring responsibilities, as well as physical and mental health issues. With a person, I think sometimes is when they disclose what's been going on, that validation is incredibly important, as we spoke to earlier. Sometimes naming the violence that there's never had a name to it as well. So for example, Angela, it seems that you've been experiencing domestic violence. Is that something you ever have thought about before? And highlighting that it's not their fault and what's been going on. Just because someone's old doesn't mean that they do not have autonomy. It's important that we help people to explain what choices they have and help them, empower them to make decisions. We often have to take a multidisciplinary approach for a comprehensive assessment tailored to interventions and to help mitigate risks. Within our team, we're lucky that we have a coordinated care with social workers who can then provide more information and help supporting a woman with access to legal services, support services, homes. But also within our network is trying to give support by bringing in aged care services to home. For Angela, that meant that she was not exposed to Tom or having to provide the care needs for Tom, and it takes her out a little bit more of the situation. And also giving options around residential aged care facilities as well for Tom to move into. As the doctor, I'm looking to treat any issues that could be there. For example, with Tom, trying to treat delusions that may be affecting or making potential violence worse. Involving our psychologist to provide some psychoeducation around intimate partner violence, as well as dementia, and helping create some behavior management plans to help manage this situation. In the case of Angela, she didn't want to go to the police and she didn't want Tom to move out, nor does she want to move out herself. So in making sure we put up a safety plan to make sure Angela knows how she can access care and keep her safe. In summary, we under-recognise intimate partner violence in older people. Screening can be challenging and we often forget to do it with older people, but it's important to look for those signs to be able to do the screening and ask older women those questions. There are nuanced approaches with older people because of some complexities within their care arrangements, but with the help of our coordinated team, we can help tackle this issue. Thank you. And Michaela's going to speak a little bit more. She's a third-year medical student at University of Notre Dame, and she's previously completed a Bachelor of Nursing and has worked as a perioperative nurse in metro and rural settings for 5 years. Her rural experience sparked an interest in Indigenous and rural health with a focus on access inequality and a passion she hopes to take into her future medical career.
Great, thank you. So I'm Michaeli. I'll be focusing on an important but often overlooked area of gender-based violence, being the financial and emotional abuse, usually by a child or by another family member or carer. So older women are in a position where ageism intersects with gender-based discrimination. So thus they're more likely to be victims of abuse, including at the hands of their own children. It's estimated that approximately or more than 50% of people who perpetrate abuse against older women are a family member. And the prevalence is estimated at approximately 17% in community settings globally, and the most common form is psychological and financial abuse. But the true prevalence is likely much higher than this figure, as there are many barriers to disclosure of abuse, especially when it's being perpetrated by a family member who they may be dependent upon for care. And there are additional layers of complexity that come into play for those in rural areas, from a culturally or linguistically diverse background, of a lower socioeconomic status, or experiencing cognitive impairment and other disabilities. So financial abuse is commonly perpetrated by children or other family members. It may look like threats and coercion regarding the older person's assets, taking control of their finances, which may look like gaining access to bank accounts and other financial documents, denying them access to their money, stealing possessions or other assets, as well as it may look like abusing their rights as a power of attorney. Older women in particular are more susceptible to this form of abuse, as they may have already experienced a lifetime of income inequality, lower rates of workforce participation, and greater expectations to take on unpaid carer roles throughout their life. So all of these factors create a situation of greater vulnerability and dependence on their adult children, which may be taken advantage of. There are additional factors like cognitive decline, sensory impairments, difficulty with technology-based finances, and fear of family breakdown that contribute to a risk of financial and psychological abuse, as well as contributing to a reluctance to disclose or seek help for this abuse. It's important to note also that financial abuse is also often enabled by coexisting psychological abuse. The tactics like fear, intimidation, blackmail, and manipulation are often used to gain access to their finances and restrict financial autonomy. So health practitioners can play a vital role in the early identification and intervention of this form of abuse against older women. Different indicators to look out for include that some older women may show signs of distress, anxiety, or reluctance to speak when a family member is present. Similarly, if a carer appears to answer all the questions instead of allowing the older person to contribute in discussions about their own care. And more specifically for financial abuse, there may be a recent or sudden change to their will or power of attorney. There may be concerns around money that has gone missing, or the older person being otherwise confused about their financial situation. They may make statements to indicate that their child or other family member handles everything now, and also noting that all of these warning signs may be of particular concern if they're a sudden change from how the older person has previously managed their finances. In order to improve the identification of older women, especially kind of in a primary healthcare setting, the routine use of a screening tool can aid in identifying those who are currently experiencing or at risk of experiencing abuse. There are many different tools and questionnaires used globally, including a couple that I've listed here that are specific for financial abuse. So that includes the Older Adult Financial Exploitation Measure and the Lichtenberg Financial Decision-Making Screening Scale. So these tools essentially aim to identify signs of exploitation, coercion, fraud, as well as assessing an individual's susceptibility to this form of abuse. There's also different forms that they come in, shorter forms that may be more accessible in certain situations. Importantly, the implementation of these screening tools not only identifies cases of abuse, but it opens a discussion with patients. So it provides an opportunity to discuss the risk factors, different prevention strategies, the importance of putting enduring appointments into place, and also providing resources that may be of use, such as elder abuse helplines, community and legal services. So it's vital that the referral then to the appropriate services is made after the screening has been implemented. It's not enough to identify those at risk of potential abuse. You then need the early intervention with the accessible specialized services to allow the prevention of the ongoing abuse and long-term impacts of that. So in summary, importantly to not underestimate the prevalence of this form of abuse. It is very prevalent, and the routine screening of all these patients can help ensure that no one is going unnoticed and slipping through the cracks. And then the main point being to refer them to relevant community and legal services, which is absolutely essential. Thank you.
Anais Fernandez Ferguson holds a bachelor's degree in liberal arts with a minor in psychology and a public speaking leadership certificate from Cornell University. She is currently pursuing a master's in social service at Fordham University and has over 8 years of experience working with adolescents, along with experience supporting older adults living with dementia and Alzheimer's disease. Anais is passionate about macro social work, particularly advocacy, community empowerment, and policy change.
Thank you, Maria, for the introduction. My presentation is about a deeply important but often hidden issue in elder abuse against women. We'll explore what elder abuse is, why older women are especially vulnerable, and what we can do to protect and empower them. What is elder abuse? Older women face greater risk from gender, ageism, and dependence. Elder abuse happens when someone a person trusts, a caregiver, family member, or professional harms them through abuse or neglect. Older women are especially at risk because they often depend on others for care and may also face both gender bias and age discrimination. There are different types of forms and expressions of abuse, not just physical harm. It can also be emotional manipulation, financial control, sexual harassment, or simple neglect, like ignoring basic needs. Each form violates a person's dignity and trust. What the data reveals. Studies show that emotional abuse is most common among older women, affecting nearly 1 in 4. However, these numbers likely underestimate the problem because many women never report abuse due to fear or shame. Why it stays hidden and prevention efforts. Many women stay silent. Some feel shame, others fear losing independence or being institutionalized. Thankfully, prevention and programs are growing. Harvard's initiatives focus on safe shelters, training caregivers, educating clinicians, and preventing elder fraud. We must have empowerment and call to action. So to truly end elder abuse, we need both awareness and action. We must educate caregivers, health professionals, and families to recognize the signs of abuse early. Older women often rely financially or physically on others, so promoting independence and financial literacy helps protect them. We also need stronger legal systems and reporting mechanisms so that we can seek justice without fear or shame. Beyond policies, community plays a powerful role. Peer support groups and intergenerational programs where young people can learn from older adults help break isolation and restore dignity. Finally, we must include older women's voices in policymaking. They are not just victims, no. They are survivors and experts in their own experiences. Empowerment means giving them the seat that they deserve at the table. Thank you. Now I have the warm pleasure to introduce Dr. Karen A. Roberto, who is a University Distinguished Professor, Executive Director of the Institute for Society, Culture, and Environment, Senior Fellow at the Center for Gerontology at Virginia Tech. Her research focuses on aging, including rural health, dementia, caregiving, and elder abuse. She has secured millions in research funding and published 245 scholarly works, including 17 books. Dr. Roberto is a fellow of the American Psychological Association, the Gerontological Society of America, and other leading professional organizations in aging and psychology.
Thank you very much. And it has been just a joy to be here and to listen to the presentations and see really how they coalesce. So I'm going to repeat some of what we've heard and perhaps add some nuances when we talk about violence in the lives of older women. First, if we think about prevalence, so we know that IPV is a significant health concern, and it is one where it occurs in late life but is often ignored. And part of that reason is that the systems that we have in place. So if we think about how the kind of entree into getting assistance and getting support, that the domestic violence side of services tends to focus on younger individuals, whereas individuals that go through adult protective services are older individuals. And adult protective services don't ignore IPV, but they tend to talk about in terms of abuse broader in terms of family abuse. So we have some of these discrepancies because of the overlap or the silos that we are dealing with. We believe, and from national surveys, that about 1/3 of women over age 50 are indeed victims of violence each year. If we look even deeper into that, about 23% of women age 70 and older report being abused. And sometimes that is just by an intimate partner, but as you see there, almost the majority of them were in abusive situations where they were being abused by both an intimate partner as well as a non-intimate partner. And the violence just doesn't stop with the act. It really impacts health and quality of life. So we know that expressions of violence change with life. I have a colleague who talks about going from hands-on violence to hands-off violence in later life. So physical violence and sexual abuse tends to decline with age, but newer or intensive types of psychological and emotional abuse tends to increase. So we've heard tonight all the different types of abuse, whether they be verbal or behavioral or physical, that really can impact the lives of the older women. And you see some examples of as some of the women were explaining their stories to us. How do we think about this in terms of some theoretical framework? So I appreciate the work of the physicians and the practitioners and those of you in social work, but I'm a researcher. So how do I think about abuse, and how do I think about bringing to forward the information that we find? And I think that theoretical frameworks become important to all our work. And so when we look at the IPV and late life literature, we see really kind of 4 ways that theory comes into play. One is in terms of social norms and gender influences, and we look at dynamics throughout the woman's life. Intersectionality, how does being a woman intersect with age, race, health, class, that really sets up some vulnerabilities and choices for older women. Structural factors come into play as well. So past socialization, current norms, ageism or age biases. And a life course perspective is really very important. Although a person may not recognize that they have been in or have been observing abusive situations, it really, early life trauma really can have a influence on relationship patterns in late life, whether that is having the person kind of pull away from relationships or get into that cycle of violence. So there's several gaps in the research literature, and there continues to be. So we know little about the history or the experience or the specific needs of older women, and it's really very exciting to hear some of the intervention approaches that are being used. One of the things that we wanted to do, we were working with our rural community, and we were fortunate to have a project funded by NIA that allowed us to look at intimate partner violence in late life from multiple perspectives. And so what I'm going to share with you tonight is really from the older women's point of view. So we looked at how the social, cultural, and historical context shaped the lives of the older women and the experience of their abuse over the lifetime. We were also really interested in what could communities do. One of our partners was the Women's Resource Center in our area. And if you're not familiar with Blacksburg, we sit in Southwest Virginia, so very rural area. So part of the reason, outside of growing up in a rural area, that a lot of my research focuses in that area. And so we were curious, we wanted to ask them, we wanted to hear their voices, which are often not addressed in the research, about what would be most helpful to them. So we did this by doing in back one, please. Thank you. We had 10 older women where we talked with who had left a abusive relationship in their later years. And we did qualitative interviews with them. They were quite lengthy, and the women really, with the help of our colleagues at the Women's Resource Center, were very willing, after several meetings, to open up and share their stories with us. So the interviews, we focused on the type of violence they experienced and how it affected them and what resources they would find helpful. We used a thematic analysis and identified patterns in the interviews that they shared, and we looked at those within what was happening and then across cases. So one of the first things that became obvious was the pathways to abuse or violence in late life, as there are many. So we really saw 4 different ways, so that some of the women talked about being in a series of violent relationships. So they were kind of going from one violent relationship to another. Sometimes this started in childhood. Other women were in long-term violent relationship that they were had a long-standing relationship, and it was a single relationship, but they maintained that. For others, that long-term relationship really started in late life, and so it wasn't until much later that. And finally, we had women talk about violence in new relationships in late life. So one size does not fit all when we try to think about the history and where people are coming into or being faced with violence. So I'd like to share with you the 4 themes that we came about, and then I'll give you some examples of that. So the women use the past to account for the abuse in their relationships in later life. The most compelling finding in our data was really the description of a lifetime of abuse, that the women really spoke, many of the women had experienced some kind of abuse as children, or there was trauma in their family of origin. And 5 of the women said that they had experienced physical or sexual abuse at themselves as a child. But not every woman described being abused, but they did talk about not necessarily having supportive relationships. And then we saw that too in the marital abuse. So even if they had escaped childhood abuse, whether it was for themselves or what they observed, they often encountered it in their own relationships. 9 of the women out of the 10 had been in multiple abusive marriages or serious partnerships with men. And even though they had experienced abuse in the past, it didn't really alert them that there was early warning signs that was happening. And in particularly the controlling behavior that we've heard about before. The one woman who reported him being only one relationship spoke about these warning signs that she missed. She said, "I guess they were there in some ways when we were first married. I looked at as being loving and wanting to be with me, but always wanting to go with me if I went somewhere. So she was feeling like that was the way that her new partner was paying attention to her. Another woman said that she put up with her second husband's bossiness because he treated her better than she had experienced before. And so there was a multitude of reasons of kind of what they knew and then where they were at this particular time of the interview. The second theme that we identified was kind of the point of recognition and action. So, what signaled the women to fight back, literally and figuratively, and to exit the relationship? 8 of the women described that they had learned to navigate abusive relationship from the mistakes they had made. But unlike their younger selves who felt that they must be subservient to their husband, the women recognized, oftentimes with the help of a therapist, that their partners had crossed a line and began fighting back. One woman told us, well, now see, like about 6 years ago, he started making wisecracks and doing things that were so much like my first husband that I kept saying, this can't be real. This can't be happening again. He didn't drink. She couldn't believe her partner was becoming verbally abused and repeating the same pattern that she had experienced as a young woman. She thought sought therapy because she thought she was causing the abuse when she was attempted to resist the controlling behavior that she was facing. She said the relationship ended when she realized that she couldn't fight for her rights. She simply had to get out. In addition to exiting the relationship, other women, back to the other slide, please, the other women fought back physically. And so this is something that isn't often expected in later life. But in fact, the women fought back. They talked about sometimes as their husbands or partners became frail, that it gave them a sort of a hands up. And so one of the women was asked or she said that when she was younger and she didn't know how to fight back, she was hospitalized because her spouse would beat her. And we asked, well, how about any injuries with the current partner? And she said, no, because I fight back with him pretty good. But it was not until he choked her to the point of unconsciousness that she left him for good. So they do fight back physically, but they also avoid behaviors. So they kind of walk on eggshells is a common euphemism that we heard, or they lock themselves in the room so that they're not faced with these. Our third theme was about rebuilding. And so the women looked at moving on with their life. But this really wasn't without some long-term consequences. So financial abuse and exploitations was significant among the types of abuse. So there's a lot of poly-victimization going on. And they often had fewer financial resources, and they may have lost a lot of their earning potential now that they were in their 60s or 70s. They talked a lot about mental and physical health concerns that had occurred over the years and now were accumulating, and worriness about what they were going to do, especially if they felt they didn't have the money. And then finally, to hone in on the geographic area, there was a lot of isolation, which they said presented barriers to accessing resources and resisting the violence that they were experiencing. So we can be isolated anywhere, but in rural areas, and particularly in our rural area where there's long distances between homes and services, and oftentimes, particularly in the smaller communities, everybody knows everybody and can be related to a lot of the same people, so put them at risk. And finally, our fourth theme was about supporting them as older women. And I think the words that came out clear was educate, empower, and ensure safety. So they talked to us about wanting community-wide education so people recognize this to happen. But also that when they did go to a physician, they wanted to be more discreet. And I love the story of one person who told us that her physician had, she would go in and talk with her, she had all these things on her desk. And she said, I was fiddling around waiting for her, and I turned one of them around, and it was just a list of questions. and it was about being abused. And so she was sitting there talking to her physician, and sort of in the midst, she said 378. And that was the sign to her physician that there were some issues going on. We talked to the physician, and she said never again has she turned those questions to her. She gives the older women that opportunity. The other things that they talked about was really the professional sensitivity, recognizing just because they're a woman, just because they're old, just because they look okay, doesn't mean they're not under duress. And finally, what are the support options? Whether that be long-term shelter or housing or wraparound support so they didn't need to leave their home and their pets and sometimes their farm animals to get out of the situation, that there was ways to help them in through the services in their community or services that needed to be there in their community. So all these findings really have implications for practice that have been previously talked about, but just as a reminder, screening becomes really very important to try to prevent situations from escalating. Certainly trauma-informed care, really supporting the woman's resiliency and aging. We just don't want to pluck them out of a situation, but really provide them with the tools necessary to rebuild. And then resource development, really needing to be culturally competent in the services and to be aware of what the women really see themselves as needed. And finally, if we look at the needs for future research, there are many. So we could probably spend the whole conference just on that. We don't know much about diverse population. We know some preventative and intervention strategies, but they really haven't been evaluated very well. Oftentimes, we did a critical review and we found a lot of the articles being atheoretical, so not a lot of real guidance that could then be carried forward in other work. And then just from a methodological perspective, we need to move beyond the description and really think about advanced designs and robust analysis. So thank you very much.
The most important question is not what we have learned, it's what we are willing to do. Gender-based violence is not someone else's problem. It's not private, it's not inevitable, and it does not end with silence. Every one of us has a role to play. And if you're wondering whether small actions matter, remember this. Movements don't begin with massive power. They begin with everyday courage. The courage to speak, the courage to listen, and the courage to stand beside someone when it would be easier to walk away. Let today not be just a moment. Let it be a commitment that says we refuse silence, we choose safety, we believe survivors. We will be part of the change because gender-based violence is not inevitable, but change is possible when we act together. It is my pleasure to introduce our moderators for the Q&A section, Elena and Anusha, two of my fellow UN colleagues who bring both expertise and dedication to today's discussion. Their work reflects a strong commitment to advancing the UN's mission, and we are grateful to have their leadership guiding this conversation. Please join us in welcoming them. Thank you.
Hi, everybody. Thank you so much. I just want to thank everybody that came today just to give space and time and energy to this issue that we find so important. I know us as the UN students are super grateful. We put so much work and effort into this presentation for you all, and so I hope that you guys really enjoyed it. So we have about 12 minutes for our Q&A, and I just wanted to make it a nice discussion for everybody. So it was a heavy topic that we just talked about, so we can take a nice breath. And I'm assuming everybody has thoughts and comments and questions. So I feel like this is our time to come together and just share those thoughts with the group. So you're more than welcome. Anybody's welcome to throw some things in the chat and I can read them out loud, or raise your hand and somebody can speak out loud, okay? I know that there was already conversation and questions in the chat. So I know I have one question, which reads, are victims assured with access to justice if older women are reluctant to report on family members or caregivers who abuse them? How is such abuse reported? Only when physicians notice signs of abuse? So, does anybody want to take some of those questions from our panel or our guest that spoke?
I think sometimes, at least what some of my colleagues tell me, particularly from APS, is really it may not happen the first time, but they need to build trust with the women. So, and particularly in parent-child situations where they don't, no one wants to admit their kid is hurting them, right? Or stealing from them or whatever that is. And so, I think a lot of times, and I think all of you study in social work, where it becomes so important to really, somebody said it earlier, like give space to talk, and it's not a quick fix. So we want it to be because we don't want people to be in harm's way, but sometimes it really just takes, it's a process, and it takes more times, and sometimes it'll never change.
Yeah, thank you so much, Karen, for that response. I can definitely agree with that. In social work, probably all the social workers here have heard like meet somebody where they're at, or you have to just kind of, rather than going with a fix it mindset, you have to understand the why, the what, the how. And I think oftentimes people jump from that question. So thank you so much for your response. Gabriel?
Thank you very much. I've got no legal background, but a few of my friends are magistrates and judges in New South Wales. And in New South Wales, if a man is actually violent to a woman in her house or in the street or anywhere, that is often caught on body cam, and the police press the charges and take it to court. So you don't often have to wait for a woman to press the charges. So that's a new development. There's a lot of education of the judges and magistrates about violence and how to deal with violence in our court system. But also there are a lot of programs for the perpetrators to learn how to change their aggression and to be aware of what exactly violence against women is, whether that's not just physical, but emotional and financial. And the courts can actually put forward that a man must attend one of these sessions. And it's a course that they've got to attend. So I think there's a lot of movement now within our legal system that they're aware that that medico-legal interface has got to be stronger, and they're working on that.
Thank you. And that makes me think of like the role of technology, I think, with gender-based violence, because there's very much a lot of pros and cons, I think, with technology just in all aspects of the world for sure. But I think with such a serious topic, it's important to acknowledge the role of technology and the development. So does any of our panelists have any comments to contribute around the ideas of technology or body cams?
I would say I agree with you, Elena. Yeah, technology. I feel that when it comes to gender-based violence, technology has made it easier, I think, for abuse on the technological side of it. That was something, that's a form of abuse, and it's just become easier. Posting pictures of people, with the doxing, even with AI now, someone can create images of someone that has no basis in reality, can, make them naked and post them online with their face. But on the other side of it, some of the perpetrators are caught because of technology. So again, it's just one of those things. But I do think that, especially with the way that AI is going now, being used in gender-based violence, I do think that there needs to be some type of legislation around it. Um, yeah, more laws when it comes to technology being used to abuse, I think.
Yeah, yeah, yeah. Certainly, technology, brings lots, makes it very challenging in terms of gender-based violence, and makes you, like really address, some of the things that happen. Uh, but on the positive side, I mean, it is possible to get out messages of different resources we have for dealing with based violence, different places that women can go and to support groups. So I mean, so this is a positive way, and everyone has like a phone, and it is aware of kind of the latest news and different options. So I mean, that's a plus in terms of technology and its availability to all people.
Yeah, I would agree. I think it's oftentimes in many issues, technology becomes a double-edged sword because it develops so fast. So as people, we can make it work for us, but then in other ways, people can use and abuse it and kind of make it work against us. And so that's the balance we see even with whether it's a camera, whether it's social media, whether it's AI, it develops so fast and it becomes hard to almost catch up with it. I have another question into the chat, which we only have about 4 minutes left, and I feel like it would be a nice question to transition us to our closing statements. So I have, besides building trust, what are our recommendations for cultural competence support in outpatient settings where the patient survivor is seen every few months and the survivor does not want to engage in reporting or leaving yet? Would the recommendation be different if they were a minor in the home?
I'm happy to answer that one.
Thank
So
you.
from an Australian perspective, it's quite different. So I don't know what it's like in America, but if there's a minor in the home, it changes whether or not it's a mandatory report. So in terms of whether you're concerned that there's a child in the home that's facing any sort of level of danger or anything, um, the doctor is required to report that one and ensure safety. But I think from what we've sort of read and sort of what we've researched in creating our presentation, the most important thing is women will come to their decision and be ready when they are. It's not a linear process. And I think it's so important from everything we've heard about just ensuring that they've got somewhere safe to come to and to talk to and to also seek help when they're ready. So while you can advise and provide them support, you also need to sort of protect that sort of therapeutic relationship so that they always feel safe and comfortable to sort of speak to you and not to feel guilty or sort of criticized for their decision to stay, because it's not an easy or a simple one.
Thank you so much for that response. Again, that goes back to reiterate what we were talking about before of definitely meeting the person where they're at because you just never know what they've been through, what type of trauma that might carry, what things are coming up for them. And so if you are truly as a practitioner, as a social worker, as a doctor, as a nurse, trying to help the person in front of you, you do have to take a step back instead of thinking this is what needs to be done and definitely focus on listening and understanding what the person in front of you actually thinks that they need for themselves. So thank you for that. I think that was a very nice transition for us to turn to Maria again for our closing remarks. And again, thank you so much for everybody joining us today.
Thank you, Elena. As we close today's conference, I would like to thank each and every one of you for showing up with openness, care, and commitment. Today, we didn't just hear presentations, we listened to experiences. We confronted difficult truths about gender-based violence and about systems that fail. This work is not abstract, it is urgent and deeply human. To our student speakers, your leadership was powerful and inspiring. You reminded us that the future of social work and healthcare is already being shaped in this room. As you leave, take with you not just information, but intention. Let what you have learned shape how you listen, how you advocate, and how you act, because conferences end, but the work does not. Thank you for being here, and thank you for the work you will continue to do.